Okay, I think we're ready to get started. Thanks everybody for coming. And it is my distinct pleasure to introduce Dr. Lois Smith to you today. I'm so pleased that she agreed to come and talk with us today about her work. She comes to us from Boston Children's, where she is a professor of pediatric ophthalmology at Harvard. And Dr. Smith has had a long and very distinguished career in pediatric ophthalmology as well as the study of ocular angiogenesis. And as part of this career, she has been instrumental in defining some of the key mechanisms for ischemia and neovascularization in the eye in multiple disease states, including retinopathy of prematurity, but also macular degeneration, diabetic retinopathy, and even MACTEL. So Dr. Smith was the first to describe a very well-utilized animal model that many of us now use to better understand ocular neovascularization, the oxygen-induced retinopathy model. And so this was her seminal work. And then she further went on to be the first to really characterize the role of VEGF in ischemia in the eye. And so many of her studies have become landmark studies in our field and have really informed not just our understanding of the biology, but importantly, our translation of that to improvement for patients with these conditions. And so that kind of leads me into another point that Dr. Smith is really the measure by which I think clinician scientists should really be held, because she has been so successful in her research endeavors and in her laboratory practice, but also her clinical practice, where she's still very active as a pediatric ophthalmologist at Boston Children's. And so as a person aspiring to be a clinician scientist at this stage of my career, I look to her and everything she's accomplished and hope to be there one day. And so I'm just so very flattered that she has agreed to come and speak with us today, and I'm really excited to hear what she has to tell us this morning about ROP disease and treatment.
So thank you so much for that very warm introduction, and it's a pleasure to be here and to see old colleagues and friends and my daughter, who is graduating from medical school here in a couple of weeks and is going through match day tomorrow. So I have the pleasure of experiencing that with her, so thank you. So today I'm going to talk about a sort of overall basis of ROP, the basis of disease and treatment, and where we are in that journey. So ROP is still a very significant problem, and it's increasing as the neonatologists decrease mortality of low gestational age babies. So back in a decade or so ago, in 1970, more than a decade, in 1979, gestational age 28-week babies had a 95% mortality. In 2009, they had 90% survival, and it's even better at this point. However, with increasing survival of those very low gestational age children, there's more ROP. And after oxygen saturation guidelines changed with the support study and another study, there's been almost a twofold increase in ROP. So it's still a major problem that we need to deal with. This is from the Express group in Sweden, published in 2009. But in children born less than 27 weeks, this was about 500 kids, sight-threatening ROP, 34% still had sight-threatening ROP. And I'm going to also bring in the fact that they also had intraventricular hemorrhage and BPD, because these are also related to ROP in the sense that the treatments that we come up with for ROP are often important for these other complications of preterm birth as well. So as a result, ROP is really, as I call it, a canary in the mine. The retina is part of CNS, as you all know, and provides a window into the rest of the brain development. 80% of preterm babies have neurologic deficits. And the degree of ROP and the degree of IGF-1 deficit, which I'll come to in a minute, predicts neurologic dysfunction and postnatal brain growth, as well as postnatal morbidity. So we can use ROP and our approach to treating ROP as really an approach to treating the whole child. So if we can understand ROP and understand the biology behind it and what is different from the in utero environment, we may be able to help these babies. So I'm just going to go through what ROP, the mechanism of ROP is, so that we can begin to understand how we can approach treatment. So ROP really falls into two phases, and in the first phase, as the child is born into an extrauterine environment that is already hyperoxic, even before supplemental oxygen, there is loss of factors provided in utero, but again, hyperoxic environment. And this leads to cessation of the normal retinal vessel growth and vasoobliteration as well. So at this margin, which I think all the clinicians have seen. So this is avascular retina, this is the vascularized retina, but some of these vessels drop out, and then it doesn't progress further. The growth factors that are normally present are suppressed by the hyperoxia. This includes vascular endothelial growth factor, VEGF. It also includes erythropoietin, which is also part of this process, which I won't go into today. And there, as I mentioned, there are also factors lacking because they're normally provided by the in utero environment. And these include IGF-1 and the omega-3 and omega-6 polyunsaturated fatty acids. And there are many more, but I think if we can begin to think of it in these two terms, of those factors that are suppressed by hyperoxia and those factors that are not provided as they ought to be. Phase 2 begins at about 30 weeks postmenstrual age. There's really a quite sharp demarcation at this point. The retina matures neurologically with increasing metabolic demand, and this leads to hypoxia in that avascular area. And the hypoxia can either lead to normal repair, but it also can lead to neovascularization, as you see here, right at that margin. And the neovascularization then give rise to fibrosis and retinal detachment. So unlike phase 1, in phase 2, the growth factors induced by or related to oxygen control are elevated. So VEGF is up, EPO is up. So we have to be very careful about how we treat with anti-VEGF treatment in these two phases. However, those factors provided by the mother are still low. So IGF-1 is still low, and the omega-3 and 6 PUFAs, which are essential fatty acids, are still low. So it's a simpler approach to treatment if we provide factors provided by the mother, although we still need to pay attention to those factors that are HIF regulated. And as I mentioned, the transition from phase 1 to phase 2 occurs at about 30 weeks postmenstrual age, no matter what the gestational age of birth of the child. So there's something profound going on in the developmental process at about 30 weeks gestational age, and we really don't know yet what that is. So the current treatment for ROP is we control oxygen, because we know oxygen is a risk factor. So we control the duration, the level, the timing, and also the variation, because that also affects ROP. And we control angiogenic factors. So we can ablate the retina that is producing higher levels of VEGF or EPO, which is what we do with laser photocoagulation. Or we can use anti-VEGF intravitreal treatment. Or we can replace missing factors like IGF-1 or the omega PUFAs. So what is the optimal oxygen level in phase 1? So the support study that was published in 2010 looked at over 1,300 infants born between 24 and 28 weeks gestational age, and they evaluated two oxygen saturation levels, 85 to 89 versus 91 to 95, to see whether or not they could optimize the balance between ROP and mortality. And the primary outcome of this trial was a composite of severe ROP, death before discharge, or both. And what they found was that almost 20% of infants died before discharge with the lower saturation level versus a little over 16% with the higher saturation level. However, they had more severe ROP. It occurred in 8.6% versus almost 18% in the high versus the low levels. So it's a trade-off. However, because we have to take care of mortality before we take care of ROP, most NICUs have switched and are now using higher oxygen saturations. The Canadian trial, the Canadian oxygen trial, the COT group also found a similar trend, although it did not become statistically significant. It still may be that this is not the optimum oxygen level. We may be able to go down a little bit and still have less ROP without a change in, in mortality. And I think I've heard that between centers there was a great difference in mortality, and it may be ascribed to different NICU practices rather than oxygen itself. So I think that the jury is still out a little bit on what the optimum oxygen level is for these babies. As I mentioned, we can also control angiogenic factors by simply destroying the retina that is the source of these factors. And so on this side, we see what happens with diabetic retinopathy. This is almost total panretinal photocoagulation, and this is in a baby with ROP. And of course, this is a draconian measure. We really should get beyond destroying retina in order to prevent ROP. We also can control oxygen-regulated factors, VEGF in particular, and I'm going to go through how we should control that. So the work that I've done is, as you mentioned, in the mouse model of oxygen-induced retinopathy. So what we do is we take neonatal mice and put them into oxygen at postnatal day 7. There are 3 vascular layers in the inner retina, and only the first vascular layer has formed by postnatal day 7. So as they go into hyperoxia, the normal vascular development into the deeper layers does not occur, and the normal progression radially does not occur. And you get vasoobliteration of some of the formed vessels. So this is similar to what happens to the children in phase 1. If you then leave these mice from P12 to P17, these avascular areas then give rise to the factors that we've mentioned, and you see neovascularization, both in the periphery here, but also at the disc. So using this model, this work is really quite old at this point. We did this in 1995 and 1996. But we used antisense directed against VEGF and injected this into the vitreous and found that we could inhibit neovascularization in this mouse model system. This is between the 2 eyes, and we can see a significant decrease in neovascularization. However, as I mentioned before, VEGF is also important in phase 1, and we need elevated levels of VEGF at the growing front in order to develop normal vasculature. And if we don't have normal vascular development, that is what begins the process of neovascularization. So what we found was that looking at this is a flat mount of a mouse retina, and you can see VEGF in front of the growing vessels here. So this is the normal retina, the pink is the VEGF. And when we put the mice into oxygen, that pink disappears. So that is the reason that you get cessation of vessels, is that the hyperoxia suppresses the normal VEGF levels. If you inject VEGF into the vitreous as you put the mice into oxygen, you prevent that vessel obliteration. So VEGF is clearly important in that first phase. It's also important for neurovascular development. So in this experiment, what we did was we took a postnatal day 5 mouse, which has, here's the edge of the retina here. This is the normal vascular development just with the first superficial layer. And we have an area here of normally avascular retina. So this is not supposed to be vascularized. And when we use basically an anti-VEGF, this is just a compound that blocks the receptor, if we block VEGF at this point, we see a decrease in the development of the neural retina in the periphery. So VEGF is required for neural retinal development. So again, if we overdose with anti-VEGF, we will prevent normal neurologic development, not just in the retina, but that means in the brain as well as in other tissue. Anti-VEGF treatment was used in AMD for some time before it really began to be used in ROP. And it was used anecdotally, particularly in underdeveloped countries, in South America in particular. And Helen Hittner studied it and wrote this paper in 2011. And she looked to see whether or not bevacizumab, or Avastin, at half the adult dose was better than laser. The study had some holes in it. Complications were not evaluated, and they didn't look to see what happened over time. Nonetheless, people began to be a little freer about using anti-VEGF therapy in ROP. However, there are severe systemic changes after intravitreal Avastin injection. It stays in the systemic circulation after a single injection for up to 3 months. This was a paper by Emmy Hartnett, and she showed that anti-VEGF antibody also leads to later atypical intravitreous neovascularization and activation of other angiogenic pathways. So when you suppress VEGF, you may activate other pathways. So it's not a panacea in ROP. The other problem that she found was that it significantly reduced pup growth. So we have to be really careful about the use of anti-VEGF therapy. And 3 central questions arise from this. Are we using the correct drug? Are we using the correct dose? And we need to evaluate what the systemic and eye complications are. And this is difficult because these children are extremely fragile, and they have a lot of systemic complications like cerebral palsy and growth retardation, et cetera. So it's going to be difficult to evaluate that over that background. There were a lot of editorials asking whether or not we should look at other drugs. And in fact, Andreas Stahl began a investigator trial called the ROP study, where he was looking at Lucentis, which has a much shorter half-life in the systemic circulation. So he looked at 2 doses of ranibizumab in ROP, which was a quarter and 40% of the adult dose. So again, not going really low, but at least less than half the dose that was used in the Hittner study. And what he found, the primary endpoints were infants without rescue treatment after 24 weeks, which was the endpoint of the Hittner study, the ROP study, and reinjections of the same dose were allowed after 4 weeks if reactivation of ROP occurred. And this is what they found. So both doses were equally effective in treating ROP, so that they really could go to a lower dose, which is not being done in the Rainbow study, which is the one that's coming out shortly looking at Lucentis. But the really important point was that the systemic VEGF levels were not suppressed in either dose range following treatment. So the physiologic vascularization appeared to proceed faster and to reach complete vascularization more frequently in eyes receiving the lower dose of Lucentis. So I think that's something that we should keep in mind clinically, that Lucentis may be a little bit better or maybe a lot better than Avastin. There was a similar, not exactly the same Avastin trial that was run through PDIG, and David Wallace was the PI of this study. And this study was, This study was a dose de-escalation study. So the idea is to find the lowest possible dose of Avastin that would prevent neovascularization or reverse neovascularization. And what occurred here was that the doses were reduced down to 0.03, sorry, I think 0.06. 9 out of 9 eyes at 0.03 milligrams, which was 1/100th the dose, were still effective at reversing neovascularization. However, in all doses used, every single dose, even the lowest dose, the VEGF levels were suppressed systemically at all doses. So Avastin, this needs to be reevaluated, and the study is continuing so that ever more lower doses will be tried to see the lowest possible dose that would be effective. But nonetheless, the idea that systemic levels of VEGF are still suppressed after several weeks or even months is very disconcerting for a preterm infant where brain and lung development are still ongoing. So I think that's about where we are in the VEGF approach, or the anti-VEGF approach to neovascularization. So that's really treating phase 2. So how can we approach treating phase 1 to prevent the vascular loss and to promote normal vascularization so that we stop neovascularization before it occurs? So I've spoken about treating at this phase where the eye that's, has decreased levels of many factors because of hyperoxia, and we treat here to get to this point. Can we then treat at this phase to stop it? So one of the things that we looked at quite early was growth factors that were provided by the mother. So in neonates, in preterm neonates as opposed to full-term neonates, growth hormone is not an effective growth factor. Growth hormone doesn't kick in until about 40 weeks gestational age. So IGF-1 or IGF-2 is the important growth factor in the first trimester and part of the second trimester, but IGF-1 is the growth factor in the third trimester, which is the trimester that's missing after preterm birth. So IGF-1 levels fall very rapidly from the in utero levels after preterm birth. So this just gives you an idea. This is a study that came out of Sweden, and these were the average IGF-1 levels, which was about 10 nanograms or micrograms per liter. And these are the normal in utero levels up here. So it's almost as bad as having no insulin when you're a diabetic. There's really almost no growth hormone, or not growth hormone, but a growth hormone, IGF-1, present. IGF-1 has a lot of very important functions. It increases progenitor cell potential. It acts like insulin and has effects in glucose and lipid metabolism. And it normally rises, as I mentioned, throughout mid-gestation to support accelerated growth, which occurs in that third trimester. So this was an experiment that we did showing that in IGF-1 knockout mice, we saw inhibited normal neurovascular development in the retina. This is at postnatal day 7, so you can see a very suppressed vascular radial growth compared to a wild type. What we also found is that IGF-1 receptor interaction was necessary for both the MAP kinase and AKT pathways for VEGF action on endothelial cells. So it's required for endothelial promotion of migration, proliferation, and survival. So without that, VEGF doesn't function. So even if you have VEGF present, it's not going to act. So in this study, we wanted to see whether or not IGF-1 levels correlated with ROP, with the concept being that if IGF-1 levels were low and prevented normal vascularization, it would correlate with later development of neovascularization. So This is what, pardon me, what we found is the children with the lowest levels of IGF-1, which is in the red, had the worst proliferative ROP. Those who had the best levels of IGF-1, the highest levels, had no ROP, and the intermediate levels fell between. So the white lines are the in utero levels of IGF-1, and it barely gets up, and these are the 95% confidence interval, so it barely gets up past the 95% confidence interval here. So we thought that by increasing IGF-1, we could prevent ROP. And as I mentioned, IGF-1 is also correlated with the degree of neurologic dysfunction and postnatal brain growth. So we also wanted to look at brain growth and the other complications of ROP in this study, thinking that we would have an effect on perhaps intraventricular hemorrhage, bronchopulmonary dysplasia, and brain growth. To just give you a sort of a concept of how important IGF-1 is to brain development, IGF-1 defects are very rare. These were reported in 3 studies, and you can see in all 3 studies the cranial circumference is very much reduced with IGF-1 deficits. There's microcephaly in all children and developmental delay in all kids. So our expectation was that we might have an effect on brain. This just gives you an idea of what the brain looks like. These are MRI in low gestational age preterm infants. This is a baby born at 26 weeks, and this is the MRI of brain development at 32 weeks gestational age, and this is at 42 weeks, and this is a term newborn. So you can see not only is the brain smaller, but there's also less development of the morphology and the convolutions of brain development. And this particular study is one that really hit home with me. So this is a study showing what basically the IQ measurements are of preterm infants. So a preterm infant on average, this is cognitive evaluation at 6 years of age. A preterm infant born at 23 weeks has on average an IQ just above 70, and there's a linear correlation all the way up to about 36 weeks gestational age. So improving brain function in these preterm babies is really important. Lung development is also dependent on IGF-1, and BPD occurs in these babies between 25 and 42% in this study, and a lower IGF-1 level in the first weeks correlates with later development of BPD independent of gestational age and birth weight. And it also increases somatic growth and development. So insulin increases fat deposition, IGF-1 increases growth. So although they're very similar, it really affects a slightly different axis. So what we wanted to do was to replace IGF-1 in these children this is the same graph that I showed before. We wanted to increase this to at least the 95% confidence interval of the in utero levels. So the initial study was done in Sweden, the phase 1 and the early phase 2 studies. The phase 1 study showed that IGF-1 treatment was safe, and this was a really difficult study that was undertaken by Ann Hellstrom, and she did something really clever, which was to do a safety study in these incredibly fragile babies. You don't want to just guess at what a dose is going to be. But she knew that children were given plasma just to increase volume. And there is elevated levels of IGF-1 in plasma, particularly if it's donated from, let's say, adolescent males. So IGF-1 can be really high. And she measured the level in plasma to know that what the safety profile was going to be, depending upon how much plasma these kids got. So that was at least a starting point to give IGF-1. And in the phase 1 study, what she found was that it was safe. We were very concerned about giving IGF-1 and having hypoglycemia, but this did not occur at all. In fact, there was probably better control of glucose than without IGF-1. An early phase 2 study was also completed, and then this was taken over by Shire Pharmaceuticals, who did a more complete phase 2 study. So the phase 2 results were interesting. They looked at 121 preterm infants between 23 and 27 plus 6 days. And they were randomized at birth to IGF-1, IGF-BP3 versus standard neonatal care. And this is a continuous IV infusion because IGF-1 falls from birth onward. Within the first day, IGF-1 levels fall almost to 1/5 or 1/10 what they are in utero. And there was in the children who achieved the IGF-1 levels into the in utero levels, there was an almost 90% reduction of the severe BPD in that group. In the group that had any increase in IGF-1 at all, although it did not get into that range, there was still a 50% reduction in severe BPD. There was also, in the group that achieved the levels, the pre-specified target levels, there was a 64% reduction in severe IVH. And interventricular hemorrhage is one of those complications. It's basically a stroke in these preterm infants, and it causes severe brain problems. So decreasing IVH is a very important goal. However, there was no difference in ROP. So I think there was perhaps a trend towards less ROP, but during the trial, this was when the oxygen levels were changed, the optimal oxygen levels in most NICUs. So there was a doubling of ROP during this period. So we think that that might have something to do with it, that oxygen is a much stronger risk factor than IGF-1 alone. So this is now continuing into a phase 3 trial. So we will see in the phase 3 trial whether or not it affects ROP as well as affecting BPD and interventricular hemorrhage. I think that study, more than anything, I hope illustrates the fact that if we look at the underpinning reasons for ROP, we can also affect the other complications of preterm birth. So the next part of this talk is what other factors are missing after premature birth. And it turns out that again in the third trimester, there's this massive transfer of omega-3 and omega-6 polyunsaturated fatty acids from the mother to the fetus. And these are essential fatty acids. They cannot be synthesized in sufficient quantity by humans, and therefore they have to be obtained by the diet or parenterally. And in these children who have an immature gut and have to have total parenteral nutrition, currently there is no omega-3 whatsoever in the TPN solutions. So we have really not done our jobs in trying to find out what lipids should be present in TPN so that we optimize what the nutritional levels are of these kids. Just to give you an idea of why this is so important is that, as I mentioned, the tissue status of PUFAs depends on the dietary intake, and DHA, which is one of the major omega-3 fatty acids, is a major lipid in the retina. So DHA consists of about 20% of the lipid content of the retina. It's found mainly in the photoreceptor outer segments, but throughout the retina. And arachidonic acid, which is omega-6 PUFA, is about 10%. So between the two, 30% of the lipid content of the retina are these two lipids. And I will go into other lipids as well, which are also important, although they can be synthesized. But we really cannot treat lipids as though they're all the same when we give TPN. So we looked into what effect changing the lipid levels of DHA and arachidonic acid were on retinopathy, just to have some concept of what difference this could make pardon me, in the disease process. So we did two approaches. So we had a dietary approach as well as a genetic approach. And in the genetic approach, we used transgenic mice, FAT1 mice, that express the gene from C. elegans that converts omega-6 into omega-3 PUFAs. So these are like fish mice. They act like fish in making omega-3s. We also did a dietary approach in that we took just regular C57 block 6 mice, and we put them on a high omega-6 versus high omega-3 diet. So these are both physiologically normal, but just with elevated levels. So the omega-3 diet was like a Japanese diet. The omega-6 diet was like a Western hamburger diet. They were completely matched, and we found that the milk of the mothers reflected the diet, and therefore the pups got that diet. And we found that within 24 hours, a 2% change, so this was 2% 1% DHA, 1% EPA, that is 2% omega-3 diet versus 2% arachidonic acid. There was, pardon me, a twofold increase in the ratio after 24 hours in the retina. So there's a very high turnover of these lipids in the lipid membrane, and you will change the content in the retina in a very short time. So we basically, we are what we eat, and that's true of adults too. If we're eating fish, we're going to have a better balance in our retinas than if we're not eating fish. To look at this again, we went back to the oxygen-induced retinopathy model and looking at both the genetic approach, the FAT1 mice, and the dietary approach. And we found that there was almost a 50% reduction in neovascularization at postnatal day 7 on the omega-3 versus the omega-6 diet. So this is a huge suppression of neovascularization, comparable to what we had when we suppressed VEGF. Again, you can't compare them that well, but this is a big effect, not just a minor effect. We wanted to understand whether this was a direct suppression of the oxygen effect, that is to say, by adding the omega-3 lipids, were we stopping oxygen destruction of vessels, or were we promoting normal vascularization of the retina that was lacking blood vessels, or did we have a direct effect on neovascularization? So what we found here is that there was no effect on the vasoobliteration at P12, so there was no effect on the oxygen suppression of the vasculature, but we saw better growth of normal vessels. And I think this is because we're affecting the neurons, that is, we're affecting photoreceptors, and therefore the demand for new vessels on the photoreceptors is less. We also looked to see whether or not there was a direct suppression of neovascularization. And in this experiment, what we did was at P14, when some of the vessels have already grown back, we then changed the diet so that we're looking only at the P14 to P17, the neovascularization phase. And so here we saw no change in vasoobliteration at P17, which we expected, but we saw, again, a huge suppression of neovascularization. So we're getting a direct suppression of neovascularization as well as promotion of regrowth of vessels. So we looked into what the active biometabolites were to see whether or not we can go a little further downstream to find out what is happening with these lipids. And this is a very complex slide, and I'm not going to go through all of it. But basically, what we find is that if you have a higher level of arachidonic acid versus a higher level of DHA in the membrane, there's a very high turnover. And phospholipase A2 is the enzyme that promotes that turnover. And these fatty acids then go through the same enzyme systems. They go through COX and LOX. And if it's an arachidonic acid, it produces very pro-inflammatory, pro-angiogenic metabolites. If instead it's DHA going through the same enzyme systems, it promotes resolvins, neuroprotectins, and a metabolite called 4-HDHA that are anti-inflammatory and anti-angiogenic. So by changing the lipid content, going through the same metabolism, you're producing a different series of pro or anti-angiogenic compounds. This is just a slide showing what lipids there are in the retina. So we also need to do the same kind of experiments looking at all of the major phospholipids. So these are the ones that are found in the retina, and these are the major fatty acids. So DHA, as I mentioned, EPA, arachidonic acid. The other three major fatty acids in the retina are oleic acid, stearic acid, and palmitic acid. So again, we need to look at all of these to find out what is the best balance of lipids that we can give to these babies in TPN so that we promote normal vascularization and normal retinal growth. So this study is being done by, again, Ann Hellstrom in Sweden. And what she has been doing is looking at different parenteral solutions. One is smofflipid and clinoleic acid, and intralipid, and looking at the combination of these to see what will optimize the normal vascular development and minimize neovascularization in these children. And as a secondary outcome, we're also looking at growth, BPD, and brain development, because again, I think that the work that is being done in ROP will reflect brain development and lung development as well. So just in summary, this is how we can approach ROP. We can treat at the phase when the child has been born and the metabolic changes are occurring as the neural retina develops, and we can stop the neovascularization at this point. So we can increase IGF-1, which we can do earlier. We have increased IGF-1, we have increased VEGF, we can suppress VEGF. I didn't go into erythropoietin, we can suppress EPO, and we can promote omega-3 PUFAs. But we can do the replacement at this earlier stage. We can increase IGF-1, I don't recommend that we increase VEGF, but we can increase the omega-3 PUFAs as soon as the child is born. So before we see the neovascularization, to prevent this stage and to get back to normal development. So we've made some progress. We have not yet optimized oxygen levels. We are in a phase 3 trial for IGF-1 replacement. We are trying to find out the best omega-3, omega-6, and other lipids for TPN to see if we can minimize the development of ROP. And these two trials, the ROP study and the Avastin dose-lowering study, are giving us some idea of how we can best use anti-VEGF therapy and time it properly so that we're not suppressing VEGF in that first phase of ROP and worsening the situation, or suppressing VEGF for normal brain and lung development. So I want to first thank my collaborators. This is Ann Hellstrom and Ina Lofquist, who are my Swedish colleagues who have been doing most of the clinical work in this area. And these are my many talented postdocs and pre-docs. This is Andreas Stahl, who is a postdoc in the lab, who's now an associate professor in Germany, and J.S. Joyal, who is an associate professor at University of Montreal, and Mike Sapaya, who is also at University of Montreal with his own laboratory. And these are many of the pre-docs who've been involved as well. So thank you very much.